Good evening. Welcome to our second virtual community awareness roundtable entitled A Path Forward. I'm Dr. Darrell Ezell, Director for Diversity, Equity, and Inclusion at HudsonAlpha Institute for Biotechnology in Huntsville, Alabama. I will serve as the moderator for tonight's roundtable. I would like to thank our colleagues at HudsonAlpha for their support in making this event possible. Also, we would like to thank the leadership and staff at WJAB 90.9 FM on the campus of Alabama A&M University for partnering with us to simulcast tonight's roundtable live on the air. So if you're listening via radio, we thank you and welcome tonight. The purpose for tonight's roundtable, the topic will address the COVID-19 vaccine, mistrust, and community mobilization. The purpose of our conversation tonight is to provide broad insight and education to North Alabama's minority population on the alarming impact of COVID-19 and how we can stay safe. To start us off, we would like to welcome HudsonAlpha's President and Science Director, Dr. Rick Myers, to provide opening remarks. Thank you for being with us, Dr. Myers.
Thank you, Dr. Ezell, and thank you to everyone who's joined and are watching on directly. Also, I do thank our guests, Dr. Brown, Mr. Kenny Anderson, and Mr. Michael Burns, as well as Alabama A&M and WJAB. So let me just very briefly say something. I think some of you were on our previous roundtable, likely, but some of you may not have been. HudsonAlpha Institute is a nonprofit research and teaching and clinical institute here in Huntsville, started 13 years ago. We study genetics and genomics, this area, the idea of looking at all of our DNA or all of the DNA from crops, and because we do a lot of agricultural stuff and other organisms, and how we can use that information to make a difference in people's lives, a positive difference in people's lives, ranging from studying lots of different diseases, what makes us healthy, how can we improve and do agriculture sustainably, et cetera, things like that. We also, I just want to mention, just so that I hope you all can have a look at this. We have a tremendous education outreach program run by Dr. Neil Lamb, who is on attending this roundtable as well. And his team, you will hear from one member of that team today, Dr. Fenela, Candace Fenela, in a few minutes. So we don't do anything in a vacuum. Nobody really does in academia or in companies or research. We have a lot of biotech companies associated with this, but the nonprofit institute collaborates with institutions all over the world, really, all over the United States a lot, and certainly all over Alabama. We care globally, but we act locally as much as we can too. We have collaborations and do a variety of projects at the Alabama A&M, with UAH, with the other research universities in Oakwood as well, I should say, other research universities in the state. So let me just say briefly what this is about, and the previous roundtables about COVID. COVID has clearly affected us globally, and it's as Dr. Ezell said, it's affected underrepresented minorities even more. And I think part of the so we want to do something about that as much as we can. I'm not going to list the things, but HudsonAlpha is deeply, deeply involved in research, testing, trying to develop, help to develop treatments for COVID, as well as all the other diseases and things that we work with. So we're working hard to try to correct this. Unfortunately, we're able to recruit Dr. Ezell here to help run our programs that we have in DEI related issues, and we're very happy to have him. So thank you, Darrell, for introducing me, and welcome everyone.
Thank you so much, Dr. Myers. As Dr. Myers indicated, in part one of our roundtable series, we delved into a conversation to really help our listeners, our audience, to understand the basics around the novel coronavirus. Dr. Neil Lamb provided a clear understanding on how COVID-19 is contracted, the significance of the variants, and the role a vaccine will play in slowing the spread of this deadly virus. Ms. Daisy Price informed us of ways that youth and adults may protect themselves at home and at work. Professor Tanya Terry, Dr. Tanya Terry, Perry, from Alabama A&M University, provided key insight into the current mistrust held by communities of color and best practices to promote inclusive dialogue and engagement. If you haven't already, I invite you to visit HudsonAlpha.org/DEI to watch part 1. Share it with your friends, your family, your colleagues. We see these events as being educational resource tools, portable for you to pass along to inform those within your community. The goal of tonight's roundtable discussion is to provide a little science and healthy information to our North Alabama minority community that will keep you safe and informed. To do so, we've assembled a diverse panel to have a helpful conversation tonight. Our panelists for this evening's roundtable include Dr. Milton Brown, who serves as Professor of Practice and Director for the Center for Drug Discovery for Rare and Underserved Diseases at George Mason University in Fairfax, Virginia. Dr. Candace Finla, who is a clinical project manager for the pediatric genomic projects at HudsonAlpha in Greg Cooper's laboratory. Mr. Kenny Anderson, who serves as the director of the Office of Multicultural Affairs for the city of Huntsville. And also we'll have with us Dr. Neil Lamb, who serves as Vice President for Educational Outreach at HudsonAlpha. Welcome, everyone. All right, let's jump right into it. The COVID-19 pandemic has affected all people, but not necessarily in the same way. Scientists have shown that racial and ethnic minorities are more likely than non-Hispanic whites to catch, be hospitalized because of, and ultimately die from the virus. In the state of Alabama, there are 499,000 or more cases of COVID-19, 499,819 cases as of yesterday of COVID-19, and we're just over 10,148 deaths in the state of Alabama. Based on data from the CDC, Native Americans, African Americans, and Latinx Hispanic people are dying at a much higher rate than whites from the virus. Native Americans are 4 times more likely to be hospitalized, 2 times more likely to die. Latinx and African American people are 3 times more likely to be hospitalized and 2 times more likely to die from this devastating virus. Dr. Brown, please start us off with a little science to help us to understand how the COVID-19 virus impacts the human body and how can we as people of color stay safe.
Thank you so much. It's great to be with you tonight. I live in Maryland, work in Virginia, and my hometown is Huntsville, Alabama. So it's good to talk to you tonight. You know, this virus, COVID-19, has impacted our world. It's changed our world forever. It's changed our communities forever. And not one of us that are on this platform tonight can say they have not been impacted by COVID-19, whether the impact has been economic, or social devastation. COVID-19 has really come into our world and devastated us. What is this virus? What is it? What is this virus? I want to take a few minutes to explain the COVID-19 virus and how it affects. So COVID-19 is a coronavirus. It originated from Wuhan, China. We don't know if it came from someone who ate it or someone who breathed it in, or if it was manipulated in some kind of way. But what we do know is that this virus jumped from animals into man, and now we know it transfects from man to other individuals. And then we know it also can jump back into animals, and we've seen pets from homeowners being infected. So how does this devastating virus work? The first thing that I want you to know, this virus can be ingested. We see an oral form of COVID-19. We see live virus in stool, so we know that there's a viral infection of the gastric intestinal tract. The first symptoms that you see of a GI symptoms are loss of taste. So many people talk about the loss of, I can't taste my food anymore. This is the first symptom that you may have COVID, intestinal COVID infection. The second is to inhale it. And once you inhale it into your lungs, this virus comes in and it takes a spike, almost like a railroad spike, and it jabs right into the cell, into the ACE2 receptor, which is the receptor for the spike protein. Once it goes in and gets inside of the cell, it locks the door. It doesn't allow other infections to come, other COVID-19 infections to come in. And then this virus begins to replicate itself, make millions and millions of copies. This virus is very nefarious. That means it has bad intentions. And this virus, the COVID-19 virus, then goes throughout the cell and begins to harvest the good components of your cell. And then I want to tell you something about this virus that's different from a lot of other viruses. This virus goes into the nucleus and it turns off the sprinkler system. So the sprinkler system is the cell's ability to change pathways that involve inflammation. So when I say the sprinkler system, that means anything that the cell can do as an antioxidant pathway to tamp down the inflammatory process. Once it turns off the sprinkler system, guess what this virus does? It starts a fire. And this fire, once it starts this fire, and the fire is inflammation. So I'm calling inflammation fire. Once it starts this fire, the fire begins to continue to rage, and then all of a sudden, the virus sees a can of gas in the corner, and it takes that gas, and what happens when you throw gas on a fire? It accelerates. It's an accelerant. It gets really, really hot, and when that fire gets really, really hot, it releases inflammatory molecules we call cytokines, and the cytokines are in part the problem that causes this multi-organ, multi-system disease. We release these cytokines in a surge that we call hypercytokinemia, or the cytokine storm. Now I want to tell people it's not the virus that kills you. Did you know that? It's not COVID-19 that actually kills you. It's the downstream release of these inflammatory molecules that cause tissue destruction and cause inflammation in multiple tissues. This is what kills you. It's this inflammatory hypercytokinemia, or what we call the cytokine storm. It results in a multi-organ, multi-system disease. People who are infected and who get a lung disease where it's a pneumonia can go into acute respiratory distress syndrome, ARDS, which is a life-threatening disease that requires intubation and requires you to go on a respirator. Did you know that 60% of patients that go into the ICU and are put on a ventilator are also on dialysis as well? This virus attacks your kidneys. It attacks your heart. It attacks your brain. It causes a hypercoagulation state, which you get blood clot. This virus is a very deadly virus. It's translated, as Dr. Zell said, into over 520,000 deaths in the United States. Over 500 deaths, over 500,000 deaths in the United States, 2.6 million infections, and over 26 million infections, and over 117 million worldwide. So I mean, this is a really dangerous virus, and I want you to understand that the virus itself does something in the cell. When it turns off that sprinkler system, it turns off the cell's ability to fight the inflammatory process. Now, the virus doesn't come by itself. It has cousins and nephews and uncles. We call them the mutants. These are changes in the virus's spike protein, amino acid changes that cause the spike protein, which we talked about, the spike protein. It causes it to change its ability to put the key in the lock and open the door. So some changes make a better key, and so it can infect the cell even more. Some changes have no effect, and it doesn't make the virus more infectious. Also, the mutants, the reason why we have mutants is because it also wants to evade detection by the immune system. And so because of this, these mutants have become a problem. Back in April of 2020, China told us there were 30 mutants. Clearly, we knew 2 mutants. One had come from Wuhan to Washington State. Another one had come from Wuhan to UK or to Europe, and then Europe to New York. And so New York and the Washington State virus were different, sequenced different. So we knew we had at least 2 mutants. And in April, China said, we found 30. We've sequenced 30 mutants. By September of 2020, in the publication in Science, there were 12,000 known mutations. Not all of them bad, not all of them out to get you, but some are. And the result of this of these mutations have resulted in viruses that have changed their ability to infect. We have a South African mutant. We have a UK mutant. We have a Brazilian mutant. We have US mutants that developed on our soil. California has a mutant. Texas has a mutant. And those mutants from South Africa, UK, and Brazil have come to the United States or in all of our states. What's incredible is that we've actually seen now, as of this weekend, reported a double mutant, where the South African mutant and the California mutant have been found to be in those mutations in one single virus particle. So now we have a double mutant. And so now that we're dealing with these mutants, they will play a part in our ability to address them, whether it's by vaccines or by the things that will eventually really save us, will be therapeutics that you can take. So anyway, I'll stop there, and I want to just say that this virus is a very deadly virus, and one that I hope that you understand the way I described it in a way that will help you understand how it affects.
Thank you so much, Dr. Brown. I appreciate it sincerely for opening it up, providing a little science for us. Just very briefly, if you could, there are a couple of questions like, what is a vaccine? And the different vaccines that are made available. I think there are 3 right now here in the United States. Please correct me if I'm wrong.
Oh, sure. It's we have 2 types of vaccines right now in the United States. One is an mRNA vaccine. That's a Moderna and Pfizer vaccine. And how does that work? Well, the mRNA is a message for a protein. So it's just like writing a message to tell your child to do something. This mRNA is a message that the cell takes and codes it to make a protein. And guess what protein the mRNA vaccines are made after? They're made after the spike protein. And so what happens is when they inject the mRNA from the virus into your muscle cell sees that mRNA and says, I need to make a protein for that mRNA. They make a protein, the spike protein, and then your body, your cell bites off a piece of that protein and puts it on the outside of the cell, and it tells your body, there's something inside of this cell that doesn't belong. And so the body then generates an immune response, whether it's by antibody response from plasma cells, or whether it's a T cell response or other types of cells, including macrophages. But the body generates an immune response. So now, when you see this protein again from like an infection, your body should have memory for this. And so that's how the mRNA vaccines work. There's issues right now, and we're dealing with the issues of does the vaccines cover the mutants? When the virus made those changes in its spike protein, were they enough to evade the vaccine? So we don't know, and we're working. Many people are working on this issue. And then the second issue with the vaccine is, how long will it last? Well, how long will this vaccine last? The protection last? Will we see it similar to native protection, where native immunity, where when you get a COVID infection and you get better, typically you have about 3 months of antibody protection before it begins to wane. And so the question is, will we see this type of similar response from the vaccine treatment? So that's the mRNA vaccine. The second vaccine that's approved is the J&J, Johnson & Johnson vaccine. This is a virus. This is a adenovirus, and this adenovirus it has been modified, so it doesn't have, it's attenuated, so it doesn't have certain things that are important for the virus to fully infect you. What has been done is that the DNA for the spike protein, again, for the virus spike protein, is placed in the adenovirus, into the adenovirus, and then they inject that adenovirus with the DNA to the spike protein into your arm. Your body sees that DNA and says, okay, I need to make an RNA, I need to make an mRNA. And once it makes an mRNA, we know what happens to the mRNA. That's a message to make the protein. And now you have this protein, which is the spike protein, and you make an antibody response or an immune response to that protein. So those are the 2 types. There's a third type that's working on approval. That's from AstraZeneca. There are probably 200, Dr. Zell, there's probably 200 vaccines that are being in various stages of development. And over time, over the next 6 months, we'll probably see 1 or 2 more come online as well. But that's how the vaccines work. They code for all of the vaccines that we have at the moment, eventually code for a protein, which is the spike protein. And we learn why that spike protein is important. The virus uses it to jab itself into the cell and allow it to penetrate through the ACE2 receptor, which is how it gets into the cell.
All right, thank you so much, Dr. Brown. This is very helpful to provide some foundation and some context here. I want to switch gears and talk about community mobilization, vaccine mobilization, and switch gears to Dr. Fenella. Dr. Fenella, there has been a lot of conversation about vaccine accessibility and the lack of vaccine distribution in communities of color. I've received emails, and folks that I know have received emails with regards to where do I go? How can I, get better information? So I want to switch the conversation to you around community mobilization in vaccine accessibility. Thank you so much.
Okay, I have a couple slides. I'm going to go ahead and share my screen for those that are joining us through Zoom today. Okay. Can everyone see my slides? Thumbs up. Okay. So yeah, as Dr. Ezell mentioned, I'm going to kind of go through vaccine mobilization predominantly here in the North Alabama area, and then also discuss consumer hesitancy, but I'm hoping that we'll be able to have some more dialogue about that in the roundtable session a little bit later in our webinar. So there are many reasons that people are hesitant to get the vaccines. The most overwhelming thing that I've heard, I guess, being a scientist, is just that there's a ton of information coming at you and you don't have a good way to filter what is good information and what is bad information. Also just the fact that the vaccine came out so quickly. So, concerns about whether or not it's been vetted in the same way that a lot of other vaccines have been vetted. And if there has been enough testing that, we should be comfortable as a people to take it or give it to our children or give it to our loved ones. And, pair that with the general medical mistrust that we see in a lot of communities, but particularly in communities of color. And you have a complicated quandary. You have a situation where there are a lot of valid concerns and there are a ton of answers out there. So trying to figure out which answers, are addressing the concerns that you have and what information you can trust is a thing. So what I always advise people to do is use a system that works well for me, which is trying to figure out how to process this. So as we mentioned, we're all on this panel. A lot of us are scientists or people who sort through a lot of data. So I would suggest that you get data from trusted sources. So as Dr. Ezell mentioned earlier, we have a DEI specific page at HudsonAlpha.org. So if you go there, we have some resources related to COVID-19. It links you to a lot of the ADPH and CDC's recommendations, but it also provides additional resources about how to get vaccinated in this community. And it provides some context or in context for scientists at Hudson Alpha. If you have questions or things that you would like for us to address to the community, then we're happy to do so. So go to the sources of the information, the people that are putting it out, do your own data-driven research. So, that does not mean Facebook or random blogs, but go and try to find the data behind all of these things and sort through it on your own, or get with individuals who are able to help you sort through that information, and then weigh the pros and cons of vaccination for you and your family. You also want to consider your impact and how you interact with the community and how you making certain choices, as far as being a good steward of wearing masks or being vaccinated or anything like that, how that might impact your community at large. So some data is to kind of look at who has already been vaccinated. Just as we have mentioned on our previous roundtable, we can see that the majority of the focus has been on the older individuals in our community for good reason, just because of a lot of the comorbidities that we see in those groups, and we want to make sure that we take care of them. So based on the data that I pulled from earlier today, the ADPH reports that about 55% of individuals that are over 75 have already been vaccinated, and about 41% of folks that are over 70 have been vaccinated. The majority of us that are under that age bracket, but are not maybe in the medical field, are still having a hard time getting vaccinated, but we're also the individuals that are out and about in the community. And so it's important to consider how you're interacting with the community so that you are being a good steward, but also to be cognizant of how your impact may be on the elderly and others around. As we mentioned before, If you take a look at who has been vaccinated, there's not too much of a difference at this point, but you can see that it is lower in lots of populations of color when you compare it to other racial groups. So who's eligible for vaccines? At this particular point, we're in group 1C, but we're still in that first phase where we're just looking at people that are between 65 and 75 or 65 and older, really. So we're hoping that in the coming weeks, we'll be able to move forward to the critical workforce. I believe that we have changed that. And so I think since then we have allowed for people in manufacturing and individuals who are working at our grocery stores and our fast food places. A lot of them are now eligible to be vaccinated just because of the interface with all of the additional people that they would see. So this is the business end of things to me, is where can I get vaccinated? So I decided to kind of look at this as, everybody, you're just searching, where can I get vaccinated? They're always kind of directing you to the dashboard for your state or to the dashboard that's put out nationally. But if you just take a look at what's around Huntsville within the 60-mile radius, because that's what they'll let you do, then you can see that you have about 84 places that you can go get vaccinated that have vaccines on hand that they're reporting to the CDC as far as we have these and we can vaccinate X number of people. So off to the side of your screen, I've kind of left a couple links to places that you can go and either sign yourself or your loved ones up for vaccines. If you go and browse around and kind of look at the timelines of when available appointments might see, they vary kind of drastically. Some of the sites that just recently got vaccines, especially in light of the availability of the J&J virus vaccine, like CVS, Walgreens, and Sam's, they have availability more readily than some of the ones that traditionally people have been shunted to, like the Huntsville Hospital or those that are pointed out through the Alabama COVIDvaccine.gov site. So I would recommend you kind of look at a couple before you sign up so that you can get something as soon as available if that's something that you're interested in doing. Of course, as of yesterday, things changed. So there was a new interim public health recommendation that was put out yesterday that basically said a fully vaccinated person, which is defined as somebody who is 2 weeks post their last vaccine. So that means if you got the J&J, it's 2 weeks after your first shot. If you got Pfizer or Moderna, then it's 2 weeks after that. Then you're considered fully vaccinated. And they have suggested that it is okay for fully vaccinated people to be indoors without wearing a mask and without being physically distanced from each other. And if they're going to be around people who are unvaccinated, then there are guidelines about what is considered safe. And that's basically everybody from the same household that is at low risk of contracting COVID-19, then supposedly that's okay for you to be around them without a mask. And then there's some changes in the amount of time that you have to quarantine after exposure, according to this guideline. For now, they're still suggesting that people wear masks that fit and stay away, at least 6 feet away from other individuals when you're in public, when you're visiting people who are at increased risk, and when you're visiting with people who have multiple households, if you're having to do that in a work setting or otherwise. They're also asking that you avoid large groups still, because the majority of folks are not vaccinated at this point. And testing regulations and everything are as they have been for the past year. So the question that I have is, or that lots of people have come to me about is, when can we expect that most people will be vaccinated? And I think that still is kind of going back and forth, but I think the anticipated projections now are somewhere around the summer or fall that we'll have somewhere around 75 to 85% of the US population vaccinated. And there's some really great articles out that you can take a look at that I don't want to delve too deep into in this particular conversation, but that'll kind of provide a little context as to why that's the sweet spot that folks are looking at and what that means for us in general. The takeaway is that if the majority of individuals are vaccinated, then the likelihood of you contracting COVID-19 or you developing COVID-19 would be significantly less than what we experience now. And what we're basically trying to do with the vaccines, in my opinion, is just knock the levels down low enough that the risk of you contracting this virus is one that is less probable than what we've been seeing, so that life can go back to whatever semblance of normal is at that point. Some other things that recently changed is the governor of Alabama decided to continue the mask ordinance until April of 9th. However, she has expressed that she is not likely to extend it past that point. However, I wanted to make sure that everyone was aware that the Madison County officials are still kind of able to extend their mask ordinance for longer if they decide. And that will likely happen based on conversations that we've heard from Madison County health officials recently. And that'll all kind of depend on the data, the county infection rates, hospitalizations, and vaccine uptake in this area. So I would definitely say keep your ears open so that you're in compliance with whatever rules might appear for our particular region. That's all I have as far as presentation on localization, but I just wanted to make sure to give you guys some resources that you can use to identify vaccines.
All right. Thank you so much, Dr. Fanilla. Is there anything else you have? I'm sorry.
No.
Okay. All right. Good deal. I wanted to make sure I wasn't cutting you off. All right. Thank you so much, Dr. Fanilla. Let me, Mr. Anderson, I want to bring you in. We've talked about the foundations around, how COVID-19 impacts the human body. What is a vaccine? We'll get into a conversation in a bit around, hesitancy. Dr. Fanilla has unpacked a bit about vaccine accessibility and what have you. How is the Office of Multicultural Affairs in the city of Huntsville working to keep minority communities safe and informed at this time?
I would say that it began with awareness back in March of last year, once the city and every other place in this nation closed down and we began getting the safe at home orders and the safer at home orders, and some people quarantining. The city immediately began having daily briefings at 12 o'clock every day. And those briefings were a process of allowing the medical professionals as well as EMA experts, government officials to talk about the landscape as it related to the pandemic and to keep people in touch with information regarding it. It's so hard to remember a year ago how little we knew because we know so much more now. But I mean, we just didn't know. There was this thing happening to people around us, and it was seeming to grow and grow and grow. And we just knew that something radical had to be done in terms of keeping people apart. So the first part of the response from the city, Madison County, the state, was just provide awareness to people and let them know everything that they could know in the moment that they had. Those meetings were taking place 5 days a week. Initially, they were scaled back a little bit when the numbers went down, and then you might remember the spike again. So we started having those briefings once again on a regular basis, and now they're just happening every Wednesday. So tomorrow at 12 o'clock, you can tune into your social media page for 1931-48 or WZDX, which is the Fox network, or you can actually check them out on a TV station if you're in front of a TV here in this area and get those updates. They are informative. I mean, they give you information about the numbers, they give you information about CDC precautions and other Alabama public health information. The key thing in this whole process for me has been it's a partnership. The city cannot sustain its ability to keep this awareness campaign and education campaign on itself. It has to rely and depend on those other entities and agencies, which are both local, statewide, regional, and national. And there has been a concerted effort to make sure that the pipeline has been sustained as far as that information sharing has been concerned. Initially, the city turned John Hunt Park, which is one of our largest public spaces, into an area for testing. And so that was one of the major testing locations in town. I was very happy to see that there were a number of churches on the north end of town, which is largely minority residents. A lot of faith communities were partnering with the Alabama Health Department in order to be able to, and Huntsville Hospital and Crestwood, to be able to get mobile applications in their community. So I know I won't name all the churches because I'll probably forget somebody, but there were a number of churches in North Huntsville that got involved in that. And I think that was extremely important very early on in the process, because again, we still didn't know a lot, and we still didn't know exactly how people were affected. We just knew this was a very serious thing that was happening. Since that time, of course, we transitioned into the vaccination process, and John Hunt Park, of course, is a major vaccination site, including the other areas that Dr. Finola noted as it relates to some of our pharmaceutical locations and more. As there is increased vaccine distribution, I'm anticipating that that will probably increase as well, but the city's working alongside all the other healthcare management professionals and more to make sure those types of things are happening. The other way that I know I have been really kind of locked and loaded on this thing is because I'm in that social service space. And I know that the economic impact of COVID has been real for people. The mental health impact has been real for people. And so I've been trying to keep people aware of resources as it relates to where they can go for these things in town. We know that most of the mental health practice has gone to telehealth. And so a lot of those services are available. And the nice thing about telehealth is that it doesn't have borders. So let's say, for instance, you can't get connected to somebody locally. You can probably get connected to somebody somewhere in order to be able to get the help that you need. So I've tried to work on being a referral source in those matters. It has probably been one of the most difficult things to watch during the pandemic, the long food lines that we've seen around the nation, the food deserts that are being created because of the pandemic and because of the economic impact on people. So just keeping people aware of all of the compassionate acts that have been taken upon many people, not just the faith community, a lot of nonprofits and a lot of other organizations, a lot of businesses have had food giveaways, and I try to stay aware of those. I know that there were 2 last week, and I know that some of our local churches have opened up their doors. My own church, First Estate Church, on some Saturdays will have food giveaways. And these things are vitally important, especially in those communities that are most hard hit by this pandemic. And so from my perspective in my office, my 30,000-foot view is often to try to understand what's happening on the ground, to try to help people become more aware, to educate, to facilitate collaboration of services. And I think that we've been doing a very effective job in some areas. It doesn't mean that there's not a lot of work that still needs to be done. We are supportive of those conversations such as this one that address the issue of vaccine hesitancy, but also I think vaccine availability is much of a challenge as anything. And that is something that we have to continue to watch. We have to continue to be sensitive to, and be able to communicate the best possible information to people as well. So we're on the ground every day doing what we have to do, and always open and willing to align our resources with anyone else who has the capacity, the interest, the ability, the willingness and commitment to be a part of that journey as well.
Thank you so much, Mr. Anderson. You mentioned vaccine availability, but also vaccine hesitancy, and just unpacking the conversation around hesitancy a bit. I want to ask Dr. Brown and also Dr. Finola, why do African Americans and other minorities have mistrust, this legacy of mistrust? We keep hearing this a lot. It's in the news. It's a challenge. It's a barrier. It's something that we no doubt will have to address and most importantly move through. But why do African Americans and other minorities have mistrust towards the U.S. Medical community? Dr. Brown and Dr. Finola, please. Please unmute.
I want to come out with some issues about why African Americans are hesitant, and I don't think it's the issue of trust. I really don't think it's an issue of trust. I think it's an issue of truth. The issue is if we can tell them the truth about this vaccines and about this virus and about the mutants that are coming and about the issues surrounding the virus, I think that our communities are able to make good decisions. The issue of trust will never be overcome. 400 years of slavery is impactful, but I mean, when we think about Tuskegee experiments, syphilis was put in our community. And that started in 1932. The surprising fact that I was 7 years old when it ended. So it ended in 1972. I mean, we have people alive. I was 7 years old. So the issue of Tuskegee is not something that people want to think that it's so far in the future. It was a part. Those people lived in my lifetime. Those experiments have happened when I was since I've been alive. And so that's why I bring up the point that it's not trust. It's going to be very hard to rebuild trust. Mm. And that's including paying pastors, leaders, giving them money to be spokesmen or to provide centers. None of that's going to really change the issue of trust. But if we can provide truth, what you're doing tonight, which many other shows, which Mr. Kenny Anderson is truly a community leader who cares about providing truth to the community in Huntsville, Madison County. If we can provide more truth, I think that the people of the African American community will galvanize towards the truth. And with that being said, I think the truth will make ultimately the impact that we want it to have.
Thank you so much, Dr. Brown. Dr. Fanilla, any thoughts?
Yeah, I was going to say, I completely agree. I think that giving people the facts and letting them do their own deduction of that information and decide whether or not it's good for them, or sort through that information and determine what their opinions are on things, that's the best way. I don't think that there is a quick fix for that.
Dr. I just want to say one other thing, that Dr. Fanilla, she did exactly today with her presentation what we need. She presented the issues. She presented where you can get the data, and then where the opportunities are for people to get the vaccines if they choose to do that. I mean, that's important. That's truth. You're providing information that will help them come to a decision that's based not on trust, but based on really truth and information.
Dr. Myers, you're with us, and also Dr. Anderson. Any follow-up thoughts? I want to make sure that I'm pulling everybody into the conversation before we get to the community-based questions, because we got a lot of questions. And if you have questions, please continue to send them.
Let me add one thing that Dr. Brown hinted at or mentioned earlier. We want facts, we want the truth. It's been interesting to see science doesn't always have all the answers, obviously. And you referred to how little we knew when this started. I think Mr. Anderson said that too, how little we knew a year ago. And we know a lot about viruses, we know a lot about biology, but this is a new one. We got lots of new ones coming up. And it's amazing how fast, because it was so devastating. We did learn a tremendous amount, but I think everyone should be, I think it's important to be prepared that sometimes things change as we learn more. We didn't know about the variants, for instance, when this was starting. We really didn't understand how it was spread until, I don't know, I can't remember which month, but we started learning, that it's different from flu. So I just wanted to mention that, and it's not like we're going to throw out all the facts that they all change. It's just things do change, as we learn more. But I also will say that I'm optimistic. We are turning the corner. I wouldn't have said that a month or two ago because we didn't know, but we're starting to see more and more people being vaccinated. Even if you've been, even if you've had COVID, the recommendation is still get vaccinated, get the vaccine, because, and that whole idea of getting the herd immunity, getting up to 70, 75, 80, 85%, is the fastest way for us to get back to normal, or something like that. I don't know what the real numbers are. I don't want to. The epidemiologists help us study this. So I just wanted to make those comments. We still have a ways to go, but I finally feel like and I think a lot of us feel like we're starting to really turn the corner.
I have a question that just came in. Homework can be done all day long on the different vaccines. How do you know which one is right for you, or are you beholden to whichever one the facility is providing? You want to jump out with them?
I was gonna say, I feel like I might have a different opinion than some other people, so I hope they speak up too. But my answer would be the one that's available to you right now, if you're interested in taking it, because I think that the concept, my personal opinion, is that I was kind of against. We talked about this a bit, so maybe this is a good time to bring that up. I was personally against getting vaccinated very early, just because I had a lot of those same concerns that I expressed at the beginning of my chat. But then upon thinking about it and weighing the costs and benefits for our family, and my husband's a physician and sees patients regularly. So the idea of bringing that into a house where we have two small children, I thought that it was worthwhile. So I would say whichever one is available to you, unless you have some reason why you shouldn't take one over the other as far as medical conditions or otherwise.
Yeah, I think the J&J vaccine is a more traditional vaccine that we're used to. The mRNA vaccines. I mean, none of the vaccines are FDA approved. They're all under emergency use authorization. So we have a little ways to go in understanding how this will play out as far as what could be better for you. But I will say the new data from J&J for the group over 60 that have comorbidities, I probably would avoid that one. If you're over 60 and you have comorbidities, that one seemed to be a little bit lower as having some effectiveness, which was like in the 40% versus like 68%. And we don't know if those are statistically different because of the low numbers of patients. But the issue, it does seem that for for people over 60 and with comorbidities, maybe you might want to try the other vaccine. But the vaccines themselves are without. We still have issues as was brought up earlier that we have to deal with. We're going to have to understand how long these vaccines will actually protect us, and develop a national plan for that. I mean, we're kind of not at the moment developing that plan. Will we need a third shot or fourth shot? And what will that bring? And so some of those issues are very, very relevant to us in the discussion of the vaccine. And that's what I mean by the truth. We provide this information so people will understand, look, you take the vaccines, this is good. You're part of this great worldwide experiment. It's important. But we have some issues that we really have to consider. And those issues are just really, will the vaccine cover us long enough so that we can achieve sustained immunity so we can get a herd effect? And the herd effect being 70%. So, some people throw out the number 60 to 70% of the entire population or micro population that would be protected. They have immunity, whether it's native, you got infected, you got better, you have antibodies that are protecting you, or you got a vaccine that gives you antibodies that are protecting you. That has to be sustained. That can't be 3 months. That has to be sustained. And that's the issue that we're dealing with. And we'll know as we get more information, and then we'll know how to adjust the shots, and maybe we have to go, instead of getting the second shot after 3 weeks, maybe we have to get the second shot at 3 months. But we'll adjust. And so those are the important issues that I think we're facing.
One of the, just to pull another question that's in the box here, would you all please share a bit about the side effects or the vaccine, and share why getting the vaccine may be better, a better alternative than not getting the vaccine to avoid side effects. So just a little bit around side effects, if there are side effects related to these vaccines.
I mean, the data for side effects, really, if you want to look for side effects, go to the VAERS data, VAERS. That's a summary of the data that comes directly raw from the hospital to the CDC, and it's reported by the CDC. They have a caveat that the data may not be assumed that the vaccine caused that particular issue. But when you consider the issues, you're considering the local issues. That's injection site. That's feeling a little bit like the cruds for a couple days. Some people have expanded symptoms, which can include up to anaphylaxis and death. And the VIRS report is very telling about the categories, including 501. The report that came out from December 20 to January 20 gives the report of 501 deaths from the vaccine, which is a little bit different from the flu virus and flu vaccine. And I take a flu vaccine every year. 9 deaths over 145 million shots, which is a little different than what we're seeing for the mRNA vaccines. And so I want people to tell the truth, and we tell the truth by telling people the risk maybe outweighs the reward. The reward you get by taking it may be better than having some severe symptoms. And so the symptoms that we're seeing with the vaccines are substantial, and we have to tell the truth. It's not trivial, and it is substantial. We've had at 35 million shots, we had 501 deaths, and that's a little bit different than what we're seeing with the flu vaccine. But COVID is different than the flu, and so we have to adjust our levels.
Any follow-up, Dr. Myers? Okay. I know that we're going over our hour time if anybody has to drop off, understandably, but we have one more question since our healthcare system was designed to serve white and suburban populations, the minority and rural populations, switching gears to focus on the rural populations, are once again left out or strained in order to have equal access to the vaccine. How can the systemic problem embedded in our current healthcare system be fixed in order to make the vaccine more readily available to minority and rural populations? So this speaks to potential recommendations to around vaccine accessibility in rural areas. Dr. Fanilla, any thoughts?
Yeah, I was gonna say, if you feel as though this is happening in your community in particular, then of course get with your local officials or individuals like Kenny to kind of get that message translated to people who can enact processes to get you access to that vaccine. I'm sure you have specific things you would want to talk about too, Kenny.
Well, I think the part of the answers in the question, the idea that this is a systemic problem that didn't just arise when the COVID pandemic hit. I mean, rural communities have traditionally had the same problem with regards to access to treatment. And we've seen over the years, I've seen over the years, medical schools who have created incentives for medical grads to take jobs in those communities, to be able to establish relationships with physicians' assistants in order to be able to create, developed strategic programs in order to be able to meet those needs. But that's a huge issue. I mean, that's an issue. We'll get on the other side of COVID, and that issue will still exist. So what COVID has done for many of us is once again focused attention again, and this is why this is such an important conversation tonight, on the healthcare disparities for minorities, on the healthcare disparities for people living in rural communities, accessibility issues, the privilege that so many of us have with regards to being able to just jump into a car. I've got a major hospital just a quarter of a mile up the street from me. You know, I feel pretty secure with that. But everybody doesn't have that experience. Everybody doesn't have that situation. So we have to be intentional in how we go about doing that. We do have to lobby our legislators. We have to lobby our healthcare professionals. We have to have internal processes within communities at the local, national, and state level in order to be able to address these issues. And we have to, I think, in many ways, demand these things. We have to stay on top of these things. And that's not to suggest that there aren't people that are doing that. There are people who've been in that trench warfare for years now, but we've got to keep the heat up until we get the results that we need. Our rural communities are not any more, expendable than any other person. We can't treat them that way. We can't create a situation where it feels that way. We have to create bridges of connectivity so that we have the capacity to reach out to these communities. But again, the question talked about systemic issue, and that's exactly what that is. It's been magnified through the COVID pandemic, but it's something that perhaps we can have more conversation around now that we once again realize that's a problem. It has to be addressed, and we've got to do it sooner rather than later.
Dr. Zelda, Kenny brings up he made a great summary about this issue. We have not just a health disparity, that is that African Americans and other minority groups contract not just COVID, but a whole list of other diseases. I mean, cancers killed 600,000 people last year. Right? I mean, COVID killed 500,000 in the US so far last year. I mean, we have health disparities, but Kenny brings up a different point, that we have health access disparities. And that's a different issue. And those issues, the issues of health disparities, and this is an important issue even for research institutes like Alpha Hudson Institute, and my institute, the genomics of health disparities. We've looked at African Americans, soldiers who got prostate cancer, and compared them to Caucasian soldier tumors. We got their tumors, we made cell lines, and we did genomic comparisons, and we found proteins in those African American tumors that weren't even in the other tumors, that were highly expressed, 7, 10, 15 times fold expressed. So there are real physiology and physical differences that occur that causes health disparities. But the issue Kenny brought up is just as traumatic, is health access disparity, where you can have health access deserts, just like we have food deserts. In rural communities, we have simply forgotten to put care centers in their communities. And we have to address that. That's not just in Alabama, that's in Maryland, that's in all of our states. And so I really, really appreciate Kenny's summary there on that issue.
Thank you so much, Dr. Brown. As we bring our discussion to a close, this is a powerhouse discussion right here. We can probably go about another hour with this one. We'll probably need another part 2 or something like that. But as we bring our discussion to a close tonight, I would like to get closing thoughts from each of you. Dr. Myers.
Sorry, I had to unmute. I couldn't find the button. No, first of all, thank you everyone for doing this. I'm a little concerned about the number of deaths that were mentioned. I'm not sure. I'm trying to look. Dr. Brown, I don't know whether you were talking about that worldwide. I was looking at the VAERS site myself. I think that's something that we ought to discuss further. Obviously not tonight on this thing, because I certainly don't want to discourage people from getting vaccinated. I think the alternative, and I know that's what you're saying too, the alternative is far, far worse. So I just wanted to mention that. I think the comments that were made were really important, and appreciate you all making them. And I also, Dr. Ezel and I have talked about this. I don't think this is going to be our last roundtable. There are lots of things I think we can and should do this for, and you know, things are going to get better in COVID, but we still have a long way to go. So we'll keep doing it for that, but for other things as well. So I think this format, I really like this format. I think it's great to hear from everyone. So, and thank you for arranging it.
Mr. Anderson.
And Dr. Myers, it's going to be great to be able to get past COVID and be able to be in one of those beautiful facilities that you guys have over there, to be able to have those face-to-face forums once we get down the road.
We want to see you. We hope so. And Dr. Brown, please visit us when we can. I meant to say that earlier. Since you're from here, come back home and see us, please.
Thank you very much.
Right.
I come back a lot. I interact with Intuitive quite a bit in other places there in the city.
That's right. Milton is a native son. It's good to see him tonight. I would say this. I think that there is a tremendous amount of optimism as it relates to the direction that we're headed in right now. And I embrace that optimism. I've talked often about the upside of COVID and trying to be able to bring some stability to some of the trauma that we've experienced and some of the excessive stress that we've experienced through the midst of this whole thing. So the upside for COVID, I think, is something that people need to consider also. What are the positive things that COVID has produced for your life? Even though there has been death and misery and despair and destruction all around us, there's some really, really meaningful, significant, positive things. I'm putting my mental health cap on right now because that's my background. And the other thing I would say to that would be an extension of that also, because I think there's going to be a wave of PTSD after this. I think that the next major frontline is going to be the mental health frontline as a consequence of what we have experienced emotionally through COVID. When you think about all of the ways that we've experienced this disease, the separation that occurred initially, the isolation for some people that occurred, the way people went through rituals such as the transition of death, where we didn't have a chance to be with that loved one or person. We're watching stories of people FaceTiming them while they're dying. I mean, those are traumatic things that people will never be able to get rid of, and they're going to have to reconcile. The people still will be grieving for many, many years to come. The economic impact that has taken its toll on our society as a consequence of COVID, the medical professional, frontline workers, the people who have been in the trenches, major mental health challenges is going to be the next frontier for us. And we have to be prepared for that. And the reason I'm bringing that up is because this is an area that's already woefully underfunded. So we have to position ourselves in a way that we are intentionally thinking about the consequences of what we've been through. And it's PTSD. There's no question about that in my mind. It will be on a spectrum of mild, moderate to severe, but it will be an absolute in so many of our lives. We have to be ready for that. So my message is take care of yourselves now, look for the upside in COVID, but let's also be prepared for the other side in terms of the ability to care for people who are going to need that care.
Fantastic points. I'm really glad you said that, Mr. Anderson.
Dr. Brown?
Yeah, we're facing a egregious monster, but we also have incredible science, and we're going to be led by our science. We're going to figure out, the frontiers of these issues include who is susceptible to this virus and why some people survive and others don't. And in the African American community, we have a health disparities, but we're also not talking about the polymorphisms that we have in the ACE protein. And we know that ACE protein is important in processing the virus and allowing it to be put on the outside of the cell. And so we know that patients who don't take, especially African American patients, we don't take ACE inhibitors because the ACE inhibitors don't work in us. We have a polymorphism. And we're not the only ones that have a polymorphism in this enzyme. In fact, when Italy was on fire, people wanted to understand why Italians were so much susceptible to this virus and all the rest of Europe wasn't. they have a polymorphism as well, and Latinos and Native Americans do as well. And so understanding more of the genomic issues that cause us to be susceptible is a really important issue. I want to leave with some important discoveries, and that's therapeutics. Even more impactful than vaccines will be therapeutics. Therapeutics are going to save the day ultimately, because they're going to be agnostic to the types of mutations that impact vaccines. And so, for example, Merck has decided that that's what they're only going to invest in therapeutics. And many of us around the country who are working on COVID-19 therapeutics, for example, turning the sprinkler system back on, being able to have molecules that turn the ACE2 protein back on to give you abilities to fight this virus with your own sprinkler system. I mean, it's a powerful new medicines that are being approaches that are coming along. We're seeing monoclonal antibodies that are made by Regeneron and Lilly now coming out of the ICU and being put into the front line, where if you come in and you get sick, we now have clinics where we can give you monoclonal antibodies as outpatients. So this is really, really powerful. This is going to make an impact on how we fight this disease, because we'll be able to give you a pill or a shot that keep you from progressing from just having symptoms to having more severe disease. And I'm excited because I'm a part of this process, and I see this process of the new therapeutics. Back last April, I wrote a review on potential therapeutics for the American Society of Clinical Oncology. And we're a year later, and now we're seeing those mechanisms come forward. It's exciting time. We have hope, but we also have to be careful, and we have to wear our masks. We have to continue to social distance, and we have to wash our hands. And one thing that we haven't said tonight, and we have to say before we close, we have to test. We have to change our lifestyle and incorporate testing into our lifestyles to keep us safe and keep us identifying people who are asymptomatic carriers, because those are the ones who are infecting others. It's not the ones who have temperatures. We can see them coming a mile away. It's the ones who have the disease, but they're asymptomatic, and we can't see them, and they infect others. So we have hope. And I want to also thank Alpha Hudson. Dr. Ezell, thank you for putting on this program and inviting me. And thank you for being a light in my community. Thank you.
Thank you so much, Dr. Brown. Dr. Fanillo, last words.
Yeah, I was going to say, I think we just need to offer a little grace to ourselves and to those around us, just in light of everything that we've experienced. Like Kenny was saying, there's been a lot going on for everybody. And so I think, allowing a little bit of grace for yourself and others is really important during this time. And then continue to stay patient. I know this has been the song that everybody has sang from the beginning, but we are really, truly getting closer and almost there. And so we can just stay diligent for a little bit longer, wear our masks, wash our hands, and get our tests, then I think we'll be in a much better place so that we don't have another spike like we did at the beginning of the year into last year. And we can actually transition to the next phase of the new normal that we will hopefully create.
Thank you so much, Dr. Fanella. And also thank you so much to our roundtable guests. Thank you as well for to our listeners that are out there. We would like to thank the leaderships and staff at WJB 90.9 FM on the campus of Alabama A&M University for partnering with us here at Hudson Alpha to simulcast this roundtable live on the air tonight. So we thank you so much. It is our hope, it is our massive and major hope that this roundtable discussion and our previous discussion and future discussions will serve as an educational resource tool for your community. We will make this video available on HudsonAlpha.org/DEI webpage. Please view and share with your family and friends. And again, thank you so much for joining us tonight. Please, everyone, have a good night.